Next talk is on evaluation and management of irregular corneal astigmatism. Tony Aldave.
I want to thank Drs. Holland and Miller for the invitation to present in this session, and thank you for coming today. My topic is evaluation and management of irregular corneal astigmatism in the patient undergoing cataract surgery. By way of disclosure, I have no financial interest in any of the products or devices I may mention during this presentation. We'll talk first about evaluation, specifically slit lamp examination, topography and tomography, and anterior segment OCT, and then management, both preoperative and intraoperative. We'll start with slit lamp examination. Here's a patient who has industrial strength epithelial basement membrane dystrophy, these grayish lines in the epithelium, probably best seen following the installation of fluorescein dye and with use of a cobalt blue light. You wouldn't miss this, I hope, on a pre-op exam for a patient with a visually significant cataract. The topography shows, as expected, significant central irregularity. This, of course, would be recognized and managed prior to cataract surgery. What about this patient, though? There's a patient of mine who I saw within the last year. This is on her pre-op examination. Cornea looks pretty good. If we lift up that lid to remove the shadow of the upper lid, that's a cotton tip reflection. Cornea is clear. My point here is that broad illumination, diffuse illumination, is not sufficient to pick up corneal pathology on the preoperative examination. You must use oblique illumination. Why? Because if you don't, you will miss this. In the supranasal quadrant, this patient has this subepithelial fibrosis extending about 2 millimeters in from the limbus. Is that of significance? Well, if you do topography, it would say it certainly is. 4.9 diopters of induced astigmatism from that subepithelial fibrosis. Let's say you missed that. You do the cataract surgery for the patient. Well, you used an average keratometry value of 41.15. Afterwards, the patient's not happy. You do a topography, you discover the irregularity, you say, I can fix this. You do a keratectomy. Now the cornea looks much more irregular, but unfortunately, the average K value has increased by 2.4 diopters. You need to recognize this before cataract surgery rather than after, and the best way is by using oblique illumination when performing a slit lamp examination. What about topography and tomography? Here's a patient I saw who had actually just had cataract surgery about 6 weeks prior. Again, with broad illumination, cornea may show a few little gray spots. With oblique illumination, much easier to see. There's patchy subepithelial scarring. The patient had a beautifully performed cataract surgery with a toric IOL, axis of orientation approximately 80 degrees. And if you look at the topography, indeed the steep axis is about 82 degrees. So lens is on axis, but we can see why that patient's not happy. That patchy subepithelial scarring, of course, is inducing irregular astigmatism. This patient is not a good candidate for a toric IOL. So it is not enough just to do a topography. You must be able to interpret that topography appropriately and then decide if that patient is or is not a candidate for a toric IOL. Not uncommonly, when you do a topography, you will see, and even in an older patient with no history of keratoconus, a bit of inferior steepening, as we see in this patient in the right eye and in the left eye. The question is, how much inferior steepening is there? Is it stable or not? And does that influence your decision regarding whether they're a candidate for a premium channel IOL? It's often a judgment call, but I think this is one of the reasons why topography should be considered in all patients prior to cataract surgery to pick up these patients with this asymptomatic inferior corneal steepening. Anterior segment OCT. I don't do this on all my patients prior to cataract surgery, but on occasion I find it a very useful tool. Here's a patient for whom penetrating keratoplasty has been performed for lattice corneal dystrophy. The patient has an irregular astigmatism on topography. It's not clear if it's because they've had a PK or because of the recurrent lattice dystrophy that's seen at the basal layers of the epithelium. OCT shows the hyperreflective layers of recurrent lattice deposits here in the epithelium, indicating that a simple epithelial debridement may be sufficient to remove that irregularity and then allowing the surgeon to proceed with cataract surgery. Contrast that to this patient who has a subepithelial scarring here in the anterior stroma, seen as the hyperreflective layer beneath the epithelium. In this case, we see it's in Bowman's and into the anterior stroma. So in this case, a PTK, if this deemed appropriate, would need to be performed prior to cataract surgery. Again, another case here where you don't want to discover this after cataract surgery and then treat because of the expected flattening of the cornea following the PTK procedure. So, what about management of the patient with irregular astigmatism? We can either manage it preoperatively or intraoperatively. And I think a good rule of thumb is to think about if they have surface disease, it should be managed preoperatively. If they have stromal disease, you can consider managing it intraoperatively. So let's take the case of epithelial basement membrane dystrophy. Going back to our patient we saw earlier with the visually significant EBMD with a high astigmatism. We've now performed an epithelial debridement with diamond burr polishing. Cornea looks much better, fairly regular with the rule astigmatism. So the question is this patient a candidate for a toric IOL? And the answer really depends on what's the chance that this condition is going to recur following the treatment. And like every decision we make in the clinic, it should be based on evidence whenever there is evidence available. We published a paper a few years ago on long-term outcomes of epithelial debridement, diamond burr polishing for visually significant epithelial irregularity. In this paper that had a mean follow-up of 20 months, but with follow-up of up to 12 years, not a single eye had a recurrence of the visually significant epithelial irregularity, indicating two things. One, that this is actually not a dystrophy, this is a degeneration. And second, that these patients are candidates following debridement for a premium channel IOL. Is that true also for Salzmann's? Well, again, we go to the literature. This paper looking at patients treated for Salzmann's nodular degeneration with keratectomy, a variety of techniques here used for removal of the nodules. If we look at the series here, this one indicated that none of the patients had a recurrence with 28 months of follow-up, but this series indicating that 31% of patients had a recurrence in the first 2 years after the procedure. So in this case, given the chance of recurrence of the Salzmann's nodular degeneration with the associated regular astigmatism, I think these patients are not candidates for a premium channel IOL. What about pterygia? Here's a patient who has bilateral nasal pterygia. We see in the right eye a higher amount of induced astigmatism, but in the left eye as well, we can see the flattening induced by the head of the pterygium. The pre-op K values, the post-op K values following removal of the pterygia, and then the delta K. So removal of the pterygium in the patient's right eye resulted in a steepening of the cornea by a diopter and a half, while removal of the pterygium in the patient's left eye resulted in a flattening of the cornea by a diopter. This is why you do not want to remove pterygia at the time of cataract surgery, because you do not know the effect of that on the average keratometry value. It must be performed prior to cataract surgery, then stability ensured by serial topographies, then proceed with cataract surgery as indicated. Now, there are cases in which you may want to consider intraoperative management of irregular astigmatism. Keratoconus is one of them. What are the criteria for implanting a toric IOL in keratoconus? Asymmetric orthogonal astigmatism, such as we see in this topographic image. You want to avoid patients with skewing of the radial axes, as we see in this topography. The patients must demonstrate topographic and refractive stability, be at low risk for progression, ideally over 50 years of age, and RGP intolerant. You do not want to place a toric IOL on a patient with keratoconus who may in the future need to be placed in in an RGP or a scleral lens, because those lenses will then unmask the toricity of the IOL that you implanted. And finally, patients with corneal scarring. Are they candidates for premium channel lenses? Well, probably not a multifocal lens, but possibly a toric. Here's a patient who I saw recently who has, as you see here, a focal scar in the mid-peripheral cornea. Higher magnification view shows some vascularization at the mid-stromal level with secondary lipid keratopathy and scarring, probably focal interstitial keratitis. Topography shows a fairly regular, although asymmetric, oblique astigmatism. Is this patient a candidate for a toric? Possibly. It depends obviously on the topographic image that you're looking at, and also depends on the chance that this disease will recur. In this patient, I would say I'd probably not consider a toric unless they had not had a recurrence of their perikeratitis for many years. So in summary, the workup of the patient with irregular astigmatism in whom you're planning cataract surgery, the preoperative evaluation should include topography, should include slit lamp examination with oblique illumination and OCT on occasion. And then if it's a surface disease, should be managed preoperatively, and if it's stromal disease, may be managed in selected cases intraoperatively. Thank you very much for your attention.
Tony, great talk. One thing you didn't touch on is how do you plan for astigmatism with concurrent endothelial disease? What are your tips for that?
So I think if you're an EK surgeon who performs DMEC, which most of us who do Fairmont EK do DMEC now, I think it is appropriate to consider toric management, toric IOL placement, astigmatism management at the time of DMEC surgery. because we're making incisions of only 2.4 to 3.0 millimeters, which have minimal effect on astigmatism. Obviously, the DMAC graft itself has no effect on astigmatism. If you're performing DSEC surgery, I think also it is possible to consider placing a toric IOL at the time of surgery, but you have to consider the effects of what would be a larger incision on the astigmatism of the cornea. If you make a scleral incision, it's minimized. And on occasion, the DSEC graft may not be planar, and so it itself may induce a bit of astigmatism. I don't think it's appropriate to be placing a multifocal IOL or EDOF lens, though, in a patient in whom you're doing endothelial keratoplasty because of decreased contrast acuity.
Priya?
Tony, a great lecture. I think there's so many great pearls on doing topography and looking for irregular astigmatism. So if you're managing Salzmann's nodules and ABMD with superficial keratectomy, when do you decide if you're going to use a diamond burr or PTK?
In that article that I showed, we summarized my results with epithelial debridement and dimer polishing, and we compared those results to a meta-analysis of all the articles reported using PTK for both recurrent corneal erosions and visually significant epithelial irregularity. And we found that both are successful procedures. The incidence of haze, however, was slightly higher in the reported series with PTK, which makes sense since you're going to be removing maybe 5 or 10 microns of Bowman's, whereas epithelial debridement, you really aren't removing any Bowman. So I think the chance of scarring is less with this procedure. So both are effective, but I find EBMD managed easier in my clinic by just doing simple debridement and polishing, so that's my preferred technique.
Great.
Liz, you have
So there are a lot of patients with EBMD that'll be outside of the central 6 millimeters, maybe under the eyelid, and Salzmann's nodules that are fairly peripheral. And they may look like they have fairly regular astigmatism on topography. Would you correct their astigmatism without first doing a superficial keratectomy, leaving that irregularity there?
Good question. Until last week, I'd never seen somebody with EBMD outside the central 5 or 6 millimeters that was causing induced astigmatism. I did see somebody, I think it was about 2 weeks ago, who had superior EBMD and induced astigmatism. But your question is regarding the patient whose topography looks normal, but they have EBMD or Salzmann's nodule in the mid-periphery. Would I go ahead and put in a toric and not treat it? EBMD I would, because like I said, with my results, if they did develop subsequently central EBMD that did induce astigmatism, I know I could treat it and it will not come back. Salzmann's nodule, I would not. Again, because if they have one Salzmann's nodule, it may enlarge, they may get a second focus, and based on this published series, knowing that it may come back, I'd say those are patients I would not consider a premium lens for.
Thank you.
Thanks, Tony. Very nice presentation.
Thank you.